Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. So I'm coming to you today from Oahu, Hawaii. It's my oh my goodness. It is my yearly vacation. Actually, I go twice a year now. In Hawaii that I go to in October, and now my husband forces me to also go at the beginning of May. He says I need the break since I do work about 7 days a week. So it's really nice, it's beautiful, and I have an ocean view, and so I'm excited today to record for you. I do take a break. This is all I'm doing today, and hopefully this topic will be something you appreciate because it's something we all deal with, especially if you are a coder that now is an auditor or vice versa. Maybe you were auditor and then you became a coder, or let's say you're both. But, as someone who has dealt with both, because, I've been a coder, you see the alphabet soup after my name, for a good part of 37 years. And now I've been an auditor for the last 20. I understand that there is a unique role that each of those roles, or I should say each of those professionals, plays in reimbursement and what we like to call, clinical documentation integrity. Remember, you can't get to improvement till you have integrity. And both are tough jobs. But the one thing that you have to look at in the tug of war between coding and auditing is that sometimes when we talk to our providers, meaning MDs, DOs, nurse practitioners, PAs, the ones that are responsible for that clinical documentation, I notice that sometimes we get information that either we don't understand or it's not appropriate. We'll say the doctor will say something like patient complains of abdominal pain, and then we don't see anything in the rest of the chart. Or they just put D/C with an apostrophe D. Something was discontinued. Or something's within normal limits, where we get these shortcuts from our providers, but we don't get a specific write-up on what actually happened. And we're trying to make sure that the doctors aren't just putting in information from macros and smart phrases and, again, clone notes, that they're actually seeing the patient. I'm seeing a lot of unfortunate things happen lately in the documentation that I am auditing, not just for providers, but for payers, where they're saying, can you take a look at this because it doesn't look copacetic. We have a problem. And I remember just recently, auditing a pediatric practice where they had documented in the note, and I know why they did. The doctor documented in real time, basically saying that the patient had moved out of, and I'm going to use two states that are not part of what I did just to protect the innocent or protect the practice. But for example, the patient lived in Texas and now they moved to Florida, and the patient was still using Medicaid from Texas, and it was actually in the note. And again, I've changed the states to protect the innocent. But you can't do that. That's illegal. It's not even a regulatory thing. It's illegal. You cannot use Medicaid. A patient cannot be covered in Medicaid in two states or move out of one state and be covered in another. There are some exceptions to emergency care, but you have to notify them, and it's up to that Medicaid state if they want to cover that emergency episode. So that's one thing. Another thing I've seen, and I'm just going to pick on pediatrics for a minute, is that I've seen that they try to see minors without the patient present. I had one where the doctor was seeing a 12-year-old boy, and it was a well check, and then the patient complained about something, and then they were also prescribing them some medicine, I think it was antibiotics, and the parent wasn't there. They dropped the patient off, and then they said, we were able to get on the phone with the patient's mother before the end of the visit. No. I checked that state for their rules on unaccompanied minor. They call them emancipated minors. And basically, minors that have been divorced from their parents and now somebody else is the caregiver, or if they're over 16, they're on their own. And from somebody who has personal experience with that, because I was an emancipated minor, I was out at 16 years old making sure that I had to have a paper everywhere I went. And that was, early on. It was in the 80s. And, I had to get in my own apartment. I was still, just finishing high school. Then I went to college early. And coming back to my argument here, when you see a patient that is not legal, you are getting in some big legal issue, the trouble there. And don't even get me started on some of the, trans stuff. I'm not even going to get into that because I'm sure you all know I'm a conservative, so you know my opinion on that. But there's a problem when, just general medical care is now being afforded to patients that you're not compliantly legal to see. And so, whether it be they're not covered, even though they have coverage because they weren't honest with their state Medicaid, or they're a minor, or they haven't told anybody about a job change. There's some legal ramifications here you have to be very careful with. And that's why I bring up this coder versus auditor and what our doctors put in our informational system and the documentation. We are looking not just at the codes. We're not just looking to see if the codes, if the 99214 is supported in this documentation. We're looking to make sure that you are able to bill it at all. Are you allowed to bill for that code? Are you allowed to bill for that patient? Is this patient even eligible to receive services? Otherwise, is it a cash pay? And as an auditor, as a coder, as a healthcare professional, you are required to uphold a high standard of clinical documentation integrity. You have to do integrity before improvement. And so think about that the next time you're looking at your records, the next time you are kind of, diving deep into what you're looking at. I'm seeing some behavioral health clinics that are saying we put a patient on medication for their opioid addiction, and I see there's nothing in there to say what the script was. I see nothing in the system to say how long, what the outcome, what the goal is, that they're testing for the patient to make sure they're not, taking drugs anymore, or that they've limited themselves. And that may not be something you can report. And so this is where it gets really dicey when it comes into the auditing and coding field, and where there's a crossover. Yes, we are looking to see if whatever level of service you billed was supported in the note. But what we don't want to see, or what we don't want to dismiss, I should say, is when there's other issues about eligibility, about legalities, about specifics within the note. Can you even do it? Are you even allowed to provide that service based on that patient's not just clinical profile, but personal financial status? And it's something that I just want to mention and hope that the professionals that are listening, medical professionals that are listening to this podcast, are taking that in consideration in addition to just the coding situation. So I know that's tough sometimes because you're thinking, well, I'm supposed to just have, blinders on anything that's not coding. Well, no, because it can reflect on you as well. If that information is in the chart, which I don't want to discourage anyone from not putting it in the chart, but when you find that information and you don't bring it to someone's attention in administration or in management, that falls on you even as a coder and auditor as well. It has to be addressed. First, was this a reasonable assumption that the patient was eligible to have these services? And then you go into, was it supported by the documentation? So I felt like that was something I had to really bring up because I'm seeing it more and more. And you have to look at that. Now, we aren't attorneys, so we can't speak to specific legalities, but we can look at, certain codes in the business and profession codes for certain states. You can look it up. And if you have a concern, like I did with this recent audit I did, you have to bring it to the administration. You have to the management and say, hey, you have a problem. And it doesn't start with coding. It starts with eligibility. It starts with compliance. It starts with, not treating minors who aren't allowed to be seen without accompanied parent. And it's up to that practice. And believe me, the payers are all over this to make sure that they are adhering to that and not just trusting when a patient comes in that they are who they say they are. That's why we get ID. That's why we make sure we, verify benefits. That's why there's such an upheaval right now about dealing with telehealth audio only, because you can't verify it's the patient. And that's where a lot of the problem lies. So I realize it's October and we don't know specifically what's going to happen with telehealth, as I am recording this a little bit before the potential shutdown. So on my next podcast, I will let you know if it ended up shutting down. I did want to give you a heads up, though, that I do have, along with Stephanie Allard, we're doing a encore presentation of our telehealth webinar that we did on September 18th, giving you the potential impact of the shutdown. So on October 22nd at noon Pacific time, 3 p.m. Eastern time, please be on a lookout for that. We will have an encore presentation to give you all the updates on what you need to do as far as the telehealth situation. So hopefully we'll see some of you join that on October 22nd. All right, everyone. Thank you for joining me today. I'm going to get out to the pool and enjoy my vacation, and I hope everyone has a good rest of your week. And yes, the Steelers won in Dublin, so I was pretty excited, and we're on a bye this week, so I definitely get to enjoy my vacation without any stress. So have a great rest of your week. Make it a great day, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.